Good morning. Thank you, chairpersons. Thank you, Dr. Khanna, for inviting me here. What I'm going to show you when there's a carotid stenosis with acute stroke. I'm a neurointerventionist, so we primarily deal with intracranial circulations. So this is the first case, 62-year-old guy who had a history of TIAs. CT scan showed a right ICA 90% stenosis. He was advised stenting by the neurologist, but he refused treatment. He was very erratic in taking antiplatelets, and there was no surprise when he landed in the emergency room with a stroke. So he came to emergency within 90 minutes. So as per the protocol, he underwent a CT scan, which clearly showed you that there will be a hyperdense right MCA sign suggesting a clot there in the MCA, plus some old infarcts, which you can expect when the ICA is 90% stenosed. He was given IV TPA, but no significant improvement, and following the trip and ship policy, shifted to the cath lab. Before the puncture, again re-examined, no improvement, and this is what we found. So you can see there's a tight ICS stenosis with a calcified ulcerated plaque, and upstairs in the MCA there's a complete occlusion. So what to do? We want to open up this MCA because otherwise he will have a big infarct, but the access is completely blocked. So we debated and discussed, and since it was just 90 minutes, there was no major infarction, we said let's stent this artery. So we used a filter device to cross the lesion once the filter device is in place so that we don't throw any further emboli. We did the angioplasty, and you can see immediately after the angioplasty, since there was a high flow system, part of the block of the MCA got opened up itself, and we decided to place a stent. And once the stent is in place, we again cross the stent with a guiding catheter. That time we were using a penumbra system. So we used the penumbra system to cross, and this is how the ICA was opened up and the MCA was opened up completely. So just to summarize, so this was the stenosis, stented, and the occluded MCA was completely opened up. And he made a very good clinical recovery, almost complete neurological recovery. Just to show you the other side of the spectrum, when it is completely occluded, this is a patient, 60-year-old, who doesn't come to us in time. She came like 6.5 hours after the ictus, acute onset left hemiparesis, very high NHS score. And this is what we call as perfusion imaging or viability imaging. Those of you who are not familiar, these are the maps which we generate, CBV and MTT maps. So whatever defect you are seeing on CBV is the area which has been completely infarcted already and cannot be revived. But here in this area, we can see that there is an area which can be revived. And if the artery can be opened up in time, this area can be saved. And the CT angiography shows again occlusion of the right MCA and complete occlusion of the right ICA at its origin. So unlike the previous case where it was 90% stenosis, here this time there was a complete occlusion of the stem. So what to do? And she is 6.5 hours after, there is already an infarct. We do not want to place a stent in first go because then we'll have to give antiplatelets. So we just crossed the lesion with a 3-5 wire and then slided our guiding upstairs, forcing the guiding through the clot, and usually they are soft clots, so the guiding goes through it. Once it is through, we can see now the circulation has opened up, the ACAs are filling, but the MCA is blocked because of that. We use a microcatheter to cross it. Once the microcatheter is crossed, we take an injection, make sure we are distal to the clot. Then we deploy stent retrievers, which is like this, which will engage the clot. This is in real life, and then you pull it out. It doesn't work like magic, so you may have to make 2 or 3 passes before the complete clot is out. So this is after the first pass, and this is after the second pass when most of the MCA has opened up. So after this, we were left with the dilemma. So far, we have a guiding upstairs, and that's why the circulation is filling. But we have forced our guiding up. We don't know what amount of clot is left behind at the ICA origin. And maybe as soon as we withdraw the guiding, the whole thing may again occlude. So we were very skeptical about it. So what we decided to place a filter through this guiding so that if there's any clot, it will get stuck into that filter. Then withdraw the guiding gradually into the ICA. Take a run, which showed a small stenosis, and we did the angioplasty. At that time, there was a good circulation. We said it's an acute stage. So we leave it like that with a good flowing circulation. Patient made a good recovery, was walking the next day. And this was the CT. This is mild hyperdensity, which is due to contrast. And this was the area which was already infarcted before we began. And this is the picture 2 months later when she came for a follow-up. And now this is classical ICA stenosis, which was stented. And this is the MCA looking nice. And this is the follow-up imaging, which showed a small infarct and no progression of the lesion. And she made a very, very good clinical recovery. Just to thank my team, Dr. Vipul Gupta, who is also here as chairman. He's the head of our neurointervention team. Dr. Jha, who is the chairman of the whole neurosciences, and our neurologist, Dr. Sumit Singh and Dr. Arunkar. Thank you so much for your kind attention.
Thank you very much, Dr. Goyal, and we have exactly 1.5 minutes for questions.
Just to give you a perspective, we presented this case to show you that in acute stroke, sometimes we would stent at the same time before going in, and sometimes we'll clear the clot and later on just do angioplasty and wait. It depends upon how large the infarct is, how good the flow in the IC is, and then stent it at the later stage. So both these strategies, sometimes one has to employ depending upon the way the situation is. So any questions?
Dr. Goyal, in the first case, which stent was placed in the intracranial part?
We used from about the exact stent.
I see. It's not wingspan or something?
No. It's a regular carotid stent what we use.
After the penumbra, you deployed a stent there?
No, before the penumbra. So first we did the regular carotid angioplasty and stenting. And once we have deployed the stent...
No, sorry, I'm okay. That's for the extracranial part.
Correct.
But inside the cranium, did you put any stent?
No. We just opened up with the penumbra device. It's like a suction device. We just suck the clot out.
Of course.
Okay. Thank you so much.